short but absolutely fascinating talks about some research that some of the doctors here have been doing. Unfortunately, the talks can only be 5 minutes, which is a shame because these research projects are huge. So if you have any questions, we'll have 2 minutes at the end, and then if that's not enough time, which I'm sure it won't be, there'll be some time at the end, and you can ask anybody the questions after. I'm sure they'll stick around. It's so tight that we've even got this very intensely for the speakers to be terrified by. And yeah, I think that's right. So without further ado, if we could ask Dr. Alex Taylor to come down.
Okay, so I did mention this earlier on, so I've possibly got a little head start on some of the other speakers, but I was really fortunate in that I was recruited by Anissa to be part of this study. This is a partnership, long-term partnership between Ghana and the Royal College of Emergency Medicine, and there was a request from our Ghanaian colleagues for a delivery of a leadership course. And so we looked at the possibility of delivering the EM Leaders course, which we know from recent research that's been published by NIFC is a really good format of kind of empowering people who work in emergency care and delivering leadership that's specific to our emergency care skill set and requirement. And we wanted to know whether or not this translated into a Ghanaian context and actually met the needs of what they were kind of asking for. So we did this as part of a qualitative study. I actually got involved, I've kind of talked through a little bit of this already, but I actually got involved at the point of the data. So the team had gone out, they had done a pre-course interview, and they had collected data about what participants were expecting. They had then delivered the course on the ground, and they had done some post-course interviews afterwards. And it was just to look at the reception, the relevance and the adaptability of the EM Leaders programme in a Ghanaian EM context. So it was a qualitative study exploring lived experiences. We were looking to see what kind of accounting for individual and cultural context and whether there were areas that we needed to adapt or whether it was appropriate for that format. There were 7 participants in total who were selected locally, although there were some additional participants that had come from local Nigeria, and these are all the Ghanaian participants were doctors working in emergency care. It was UK EM practitioners that conducted the focus groups and did both the pre and post-course interviews, and they recorded those and they were then transcribed. We did unfortunately lose one of the interviews, but we captured notes from the team otherwise around the content of that. We then engaged in reflexive thematic analysis, which I know Silas mentioned earlier on, using Braun and Clark's method to go through, extract themes, to re-evaluate those with the data, to listen back to the audio data, and just to analyse what themes we had and to try and group those together so we have kind of overarching themes that I'll come to. We used a diasporan colleague to go back and listen to some of the audio because we were concerned that we may have missed some aspects and the kind of unsaid of those sort of human interactions. And then our themes were triangulated, so we had a meeting with our Ghanaian participants to check that they felt what we'd said was an accurate representation of what had occurred. So this is quite a busy slide, so apologies for that, but I've tried to capture, because to me, as I said earlier, I love the stories and I love the quotes. Well, we explored a bit around the motivations for why they'd asked for this in the first place, and we found that in Ghana, emergency medicine is an evolving and quite a new specialty, and so there's quite pressure to lead and to drive the specialty, and there's not always the infrastructure and the learning and the teaching to support that requirement for leadership, so people don't always feel empowered or that there's the support that's needed, and you can see that reflected in the quotes there. They had different ideas around leadership and what they were expecting from emergency in the EM Leaders course. So actually a lot of their leadership focuses on management, and so they were a little bit disappointed that there were aspects of that weren't covered in the course. However, it did allow them to reflect on what leadership was, and a lot of them came away saying that it reshaped their thinking around things like problem solving, teamwork, delegation, and self-awareness. And there was an expression also that they would appreciate mentorship being included in further EM Leaders courses. There was a real empowerment around formalising leadership into curriculum, and it really, you could sense that there was a sort of hope and an urgency in delivering this in the curriculum, and sort of discussion around how that could be practicable in terms of finances, funding and maintaining currency. But there were also contextual differences, so things like language choices. There's this excellent quote of when you're in Ghana, no one says bloke. So it's just linguistics and how we adapt that. There was a bit of a concern around sort of ability to speak out and be able to raise concerns and have these courageous conversations. There were some differences in terms of hierarchy and also in terms of the kind of fluidity of EM and the culture and how it's evolving. Needs thought around how we deliver our EM Leaders course in further future. So I'm just going to brush through these because we're under a minute, but our conclusion was that there were shared challenges across emergency care between the UK but also Ghana and in Nigeria, but there was a real relevance to the EM Leaders course, and it does translate into this environment, and there is a necessity for it and an urgent training need. However, there's a definite requirement for context-specific adaptations and to sensitively kind of capture what the group that requested the leadership require and what is important to them from leadership, so that the course can have the greatest impact to help us further emergency care. And just take-home message, so this is a quote that I particularly like, that I felt really embodied the kind of the hope and the optimism and the empowerment that came from our study. So what is the goal of this emergency medicine? That when we pool resources together, human and material, a lot can be done. And we concluded that the EM Leaders programme was positively received and demonstrated applicability in Ghanaian and Nigerian EM contexts. This study underscores the importance of cultural sensitive adaptation while affirming the global relevance and transferability of EM leadership training internationally. Thank you.
That was so much information in 5 minutes, so thank you so much. Does anyone have any questions?
Just whether anything's going to be taken forward, like are these courses going to be run out in Nigeria and Ghana as a result? Or is it just a feasibility sort of?
So our camp has other relationships with other countries, and certainly there are projects where the suggestion has been that we might deliver leadership courses, but what we don't want to do is have learning from the study and then not take that forward, because it needs to meet the needs of the participants that requested for it, and it needs to be adapted in a way that is culturally sensitive and contextually appropriate. And so I think that's the main thing that we found, but certainly there are initiatives going forward with an intent to deliver the Leaders course again, but hopefully in an adapted and sensitive format. Not that this wasn't, but just to take the learning forward.
Anyone else? I think that's about time anyway, so that's perfect. Thank you so much. And then if we can hear from Dr. Emma Butterfield now.
I thought I had 3 minutes, so forgive me if I waffle on. So I'm just going to take you through some research that I did for my dissertation for my master's, which is a systematic review of burns to civilians during armed conflict. And the motivation for doing this is that armed conflict is devastatingly common, and the patterns that we're seeing in armed conflict are changing. Civilians are targets, hospitals are targets, and explosive ordnance is increasingly prevalent in built-up areas. In fact, when explosive ordnance is used in built-up areas, 94% of the casualties are civilians. We also know from looking at military data that combat-related burns are a common injury. We know that between 5 and 20% of soldiers, injured soldiers, depending on the conflict, will sustain a burn injury. And about half of those are conflict-related, and the other half are accidental due to the breakdown of infrastructure in wartime. We know that burns are disabling. We also know that if you get appropriate early burn care, it massively reduces not just the mortality, but also the morbidity. And that morbidity has a lifelong impact, not only on the patient, but on their family. So the idea is that if we know how many patients are being burned, we can plan and resource more appropriately to try to mitigate the horrors of explosive ordnance. So I thought I'd do a systematic review. There's going to be loads of research out there. So I tried to construct a very wide-ranging research question to try to ensure that I captured as much data as possible. So the population I looked at was all civilians, and where there wasn't specific civilian data available, I disaggregated the civilian and military populations. I looked at people who were exposed to armed conflict anywhere in the world over the last 70 years, including conflicts with non-state actors. And the outcome that I looked at was the incidence of burn injury. So I also looked at papers where there were lots of outcomes reported and picked out those burn injuries. So for anyone who's done a systematic review, I'm just going to tell you this because it was so painful. My search terms identified 5,485 titles, from which I reviewed 783 abstracts, of which I got 52 full texts. And the key result really is illustrated by this map, which shows you where the papers are from. And you can see that that does not represent the global distribution of conflict. There's Iraq and Afghanistan there, but there are a huge number of just unrepresented, unreported wars. There's nothing from Rwanda, where people's houses were burnt. There's nothing from Myanmar, where people's houses are burnt and people were burnt. The other thing that really stood out from the research is the poor accuracy of the data. What it showed is that injuries due to explosive ordnance are really common, but often those injuries are enumerated as blast injury, without the actual litany of injuries included. Or people are categorised according to penetrating or blunt. Well, if you're blown up, you have both, and you're probably burnt as well. Or they're categorised according to their worst injury, which again, if you've been injured by explosive ordnance, you probably have multiple terrible injuries. When you looked at different studies of the same population, so the Iraqi and Afghan data is predominantly from UK NATO military treatment facilities, so there's multiple studies pulling out on the same database. So you've got a high quality trauma registry database, you've got researchers who are well funded pulling out the data, and you can see that actually they get disparate results. And that's probably to do with the fact that burns are coded differently according to who's reporting the data and how they choose to present that data. 1 minute. So, long story short, the median incidence of burn injuries in injured civilians is 8.7%, interquartile range somewhere between 5 and 12%. Burns are really common injuries, and these are just the ones that are getting noted. There's a much lower reported incidence in NGO hospitals if you look at the difference between military treatment facilities and NGO hospitals. And that's probably either something to do with sicker patients going to military treatment facilities in Iraq and Afghanistan, because those military facilities will only treat you if you have life or limb-threatening injury as a civilian, or it's to do with civilian patients with bad burns dying before they reach hospital in the absence of advanced pre-hospital care. I think what we can conclude is that burn injuries are common. We need to resource facilities to care for them, or stop dropping explosive ordnance on civilian populations, ideally the latter. We also really need to think about how we collect data, because these trauma registries that have been designed by the Americans for the Americans are great if you can send a research nurse out there to do an ISS score on every patient, and even still their data is not that great. What we need are instruments that are designed by clinicians working in that area that are useful for them, that are feasible for them to manage, and that actually enumerate the full litany of injuries that someone who's been blown up suffers. Thank you.
Does anyone have any questions about that research? We have 2 minutes for questions. Anyone? I have a question. So you said that it's most likely that the amount of patients that have burns is underrepresented because people are classified by their most severe injury. Would you say that from the research it showed that the hospitals are well equipped enough to deal with those burns, or would you say that that's something that also needs to be explored, whether or not there's an adequate response to those patients?
It's a really good question. I think what the data clearly shows is that there are burns referral hospitals receiving patients. So, for example, there's quite a few papers from Turkey who are taking burned civilians from Syria. Well, those patients wouldn't have been transported to Turkey if the hospitals in Syria were adequately resourced to deal with them. You see the same thing in Yemen. So I think, broad answer, no. We need more burn specialists able to work safely near where civilians are injured to avoid them having to be displaced, or only the sickest people move.
Thank you. Okay. So yeah, next we have Daniel Grace.
thank you. I'm a bit of an imposter here because I'm a GP, but thanks for the chance to tell you a little bit about a trauma training pilot that I was involved in last year. So as well as being a GP, I am the volunteer medical director of this charity called the Virtual Doctors. I could do a whole talk on that, and I'm not going to because I'm aware of time, but there's a QR code at the end. And thanks to these organisations and their names on the screen as well. So, as we've been discussing, obviously in low middle income countries we know trauma is a significant cause of morbidity and mortality. In Zambia, like many African countries, it's often a case of road traffic collisions or animal attacks. There aren't dedicated paramedics, ambulance services, it's often taxi drivers, lay people who turn up. They then hopefully take people to low resource settings where they try to cope with very limited kit, often improvising with kind of local fabrics, urinary catheters and bandages to try and stop bleeding. So our plan essentially, so we were doing a few other things involving telemedicine. We went on a 3,500 kilometre journey around Zambia, but one of the things we wanted to do was look at running some trauma pilots. So we ran 3 and a half day pilots looking at, essentially it was a very crammed PHTLS looking at basic primary surveys, ABC, in 3 provinces for around 47 clinicians. There were also a handful of lay people and police officers that came along as well. And we completed some objective and subjective feedback with that. And as you can see from here, essentially we were looking at confidence scores, 4 being very confident, 1 being much less so, looking at whether beforehand and afterwards there was an improvement or not. And this is fairly simplistic compared to some of the statistical analysis that some of my colleagues have done, but we're just looking to see is there an improvement of those scores before and after, looking all the way through from airway, breathing, circulation and so on. Overall looking at is the ability to do a primary survey improved or not. Qualitative feedback, so this is just some quotes from some of the clinicians. Essentially we're looking for themes such as improved confidence, sharpening skills, enhancing abilities, and we're looking at whether this can be cascaded through to peers and also through to lay people. And as you can see here, the ability to then cascade that down, sharing some of the resources that we've provided as well was very useful. But there are problems. So we know that, yes, it improves confidence, it improves skills, but that's just a snapshot. That's just 47 clinics. How do we capacity build? How do we then disseminate that to our partners? And that's the challenge, really. Lots of the time we spoke to clinicians and they said, well, yes, this training's great when it happens, but often we are dealing with patients. We can't get to where you're dealing with that training. If it's centralised, then it's things like cost, transport costs, time off work. How do we make that actually happen in a sustainable way? There's a lot of discussion about this. Can we do something virtual? Can we make a set of videos or something similar? We heard this morning from Professor Wallace, didn't we, about that sort of hybrid approach, which is really good. Whether that can be fully virtual, I don't know. I think there is that manual aspect, isn't there, when you're doing training, that is quite valuable. But our next project is to look at whether we can go back out to Zambia and develop essentially a locally led video version of your PHTLS, ATLS, some sort of hybrid approach, looking at the context, looking at the resources that they manage. It's called From Screen to Scene. It's a bit catchy, hopefully. The challenge, as we've heard sort of all day, is working at, well, how do we finance these kind of things? So that's where we are at the moment, really. 1 minute, excellent. And our plan is to then, so with our telemedicine platform, we've got between 300 and 400 clinicians, so we were going to again do pre and post survey responses and see will that make a difference. So if you're interested in being involved in that, I know we've been talking about research, anyone who's looking for a dissertation project or anyone who's got loads of funding as well, they can maybe get in touch. Thanks to all of these partners who enabled the expedition as well. I'll just do a quick plug. If you are interested in telemedicine, so connecting your knowledge with rural clinics in Zambia and Malawi. Scan, yeah, that one. And if you want to watch a short video of what we got up to in Zambia, you can scan that one. Thanks very much.
Does anyone have any questions about that? Yes?
So I appreciate that your first part of the study has kind of confidence. Are you going to look forwards in sort of a 3 months, 6 months, 10 months time period to look at actual clinical application and how people have felt using it in real life?
Yeah, so we're in the process of collecting the 6-month data now for that initial pilot. One of the important questions is asking whether so 47 clinicians that attended, how many of them managed to actually run something or do some teaching to their peers or lay people, and then understand the challenges around that if they haven't managed that. And then that second part, the optimistic part for next year, is then working on how can we address some of those gaps or issues that we find in this later set of questions and things. Yeah, thanks.
Thank you. And then last but very much not least, we have Dr. Grace Delmanin and Chintan Zora.
Hello, my name is Grace. I'm a nurse in the BRIED, and this is Chintan. He's an anaesthetic trainee in 7. So we were out on fellowship with Darura. Darura is a global health partnership running out of the BRIED. It focuses on sustainable partnership between a hospital called Inanuki as a teaching referral hospital. So we basically wanted to look at the implementation of the triage tool. The triage tool was implemented in 2022 by Darura, and it splits people into red, amber, green as triage priorities, red like immediate patients. This is the EMKF Emergency Medicine Kenya Foundation guideline that we use to support the triage tool. This is our way of ensuring that it is relevant to the area in which we've implemented the tool. So this is the current triage tool. It's had multiple versions. This is the one that's currently used and was used in my study. As you can see, we've added things like last menstrual period. So that was a more recent addition in this version. So we did 2 kind of small separate studies brought together. So we did an audit of 10% of the daily collected triage sheets. These are randomly selected. We did the months through November 2024 to March 2025, and we just looked at purely compliance of completion of the triage tool. We then also did a structured 11-question interview conducted to analyse the perceptions of the healthcare staff on how they felt that the triage tool had changed or benefited or worsened their experience of treating patients. We interviewed 20 people. The proportions of doctors, nurses and clinical officers represents the amount of people in those areas in the hospital. These are our 11 questions, which I'll go into as we describe the results. And this is so the red columns are in November 2024, and this is through work from Darura fellows, mainly nursing fellows, working with the triage nurses. As you can see, there's a big improvement in completion of all areas, going from an average of 50, like just over 50% to just under 100% in those months. So questions 1 to 3 kind of focused on what happened prior to the implementation of the tool. We had lots of people saying it was labour intensive, words like chaos, confusion, patients going to the wrong place. They were writing OBS on the back of a receipt, but there was no formal triage process. And then we looked at the benefits and challenges that the triage tool had. So lots of people have said it improved the patient prioritisation. There was an ongoing, some of the challenges were where they were triaging, so like there was no designated space for them to triage in. And one person actually gave an anecdotal example of how they'd noticed a reduction in blood transfusion for PV bleeding. post at all. We have no evidence to support this at the moment, but that's an ongoing idea. So then our last couple of questions were about their perceptions of the global partnership and how they felt they'd been either supported or not supported by Darura. And 100% of the people who we asked said that they thought the global collaboration could be successful and used in other healthcare settings in Kenya. And they also mentioned a lot about our simulation and other projects that Darura was based in, alongside the triage, clarification of triage and how that's assisted their patient management. So overall perceptions were positive of the implementation of the triage tool. And they think that the Global Health Partnership is perceived to benefit education, and further work could definitely be developed in more rural settings in Kenya was definitely something that they wanted. Ongoing, we have future work needs to be done more into the content of the triage tools and looking at how we can continue to improve the prioritisation of amber patients over green patients, and that's all future work to be done. And then there are some limitations, such as they were all aware that I was interviewing them as a nurse from Darura, so that may have been added a bias into their answers. And all staff were interviewed in English, and they practice in English, but there was a slight language barrier. And then obviously we got some approval through Darura, and there were consent forms signed, and it was approved by the seniors in Nanuki Teaching Referral Hospital. I'd like to thank Darura, the Global Health Fellows who assisted with this data collection, and the staff at Nanuki. Any questions? Chintan will answer.
Because it's something to do.
Any questions?
How do you, I was part of that, I know that it's very interesting that they have collaborative they exchange, so we people from BRI go there, nurses, doctors, and staff from Nanuki go to BRI. How do you think impact both sides, so Nanuki staff members and BRI staff members, to have people from Kenya in the department for region? How was your impression?
I think it's one of the things that I really like about this partnership, is that recognition that both of us from each side have our own challenges and have overcome our own challenges. So some of the quotes that you may have seen on here or may not have been up here were that actually there are huge commonalities in both of our practices, and that we can share our understanding of how we've evolved through those changes over periods of time. I think it's very easy to get stuck into that old aid structure of we're going over there to fix problems that are over there, and recognising that actually it is a shared partnership and we both have similar challenges that we can learn from one another to overcome. And I think it definitely reduces those barriers between different settings in different countries.
They I was going to say, they really like hearing about, I'll talk about my challenges in triage and in the BRI, and they're like, oh, that's similar to what happens here then, and they feel like they're not alone in those challenges. And we're trying to obviously it's not perfect, our own triage system, so it's kind of learning from, and for example, I don't ask every patient when their last menstrual period was, maybe I should. I don't.
I was also a Darura fellow, and we were part of the team that did the original pilot of this, so first off, it's really, really cool to see how well it's going. At the time, we were really worried that we would change the balance of the patient flow in outpatients versus the ED, and through changing the triage system, overwhelm the ED. It doesn't sound like that was a massive issue in the end.
No, so I think at the moment, all green patients go to OPD, and amber patients, based on whether they, it's kind of the nurse's decision based on whether they think they need to be seen in ED or in OPD. One of the main things that came across from this is people enjoy the fact that they've got the triage sheet. The patient can sit in wherever they've been assigned, and if you think they're in the wrong place, OPD can run the triage sheet round to ED and say, look, I think this patient needs to be with you. Whereas before they were saying about how they used to walk the patient round, and these patients are sick, so when they walk the patient round, they'd be like, oh no, not for us, back to OPD, and they'd have to walk all the way back. So I think it's definitely streamlined that, and I don't see ED being overwhelmed in what's happening at the moment in the NUCI.
One of the common quotes that came out was that patients were found wandering around the hospital looking for the ophthalmology outpatients, and by the time they got to those areas were shut because they're only afternoon clinics. So it streamlined that process and patients get to where they need to get to quicker.
And that was that's not us saying that, that's the perceptions of the healthcare staff. We have no actual evidence of that.
Dash!